Pleasure today. It is my pleasure today to introduce Dr. Sharma, who everyone knows as the director of the cardiac cath lab and cardiology here at Mount Sinai. He is a renowned interventional cardiology expert and well known for performing high-risk complex coronary interventions, more than 1,500 per year, with an extremely high success rate, greater than 99%, while achieving an extremely low major complication rate, less than 0.2%, and has received numerous prestigious awards from the Department of Health, the Governor's Award for Excellence in Medicine, and has served on the New York State Cardiac Advisory Board. Um, Under Dr. Sharma's leadership, the Mount Sinai Hospital Cardiac Catheterization Lab has become one of the safest and busiest centers in New York, providing state-of-the-art cardiac and interventional care for all types of simple and complex heart patients. Dr. Sharma specializes in non-surgical treatment of mitral and aortic valvular disease, including transcatheter aortic valve replacement, mitral clips, and has been dubbed the master of rotablator and is a regular feature on national and local TV, recently on CBS and TV Asia, and newspaper and magazines. He has received numerous awards, including the 2023 Master Operator by Indian Live Conference, the 2021-2022 Chief Guest, Times Square Diwali Celebration, among many others. He has authored more than 360 papers and 16 book chapters in the field of coronary intervention, structural heart disease, and safety of percutaneous interventions. He's also a philanthropist, and the Mount Sinai Hospital Cardiac Catheterization Laboratory is named the Samin Sharma Family Foundation Cardiac Catheterization Laboratory. He's been instrumental in getting a $5 million grant from the Aloha family to name him director of the newly created SP and Selma Lola Cardiovascular Clinical Institute, and has built a 250-bed heart hospital in his native India to provide the best care to all patients, irrespective of their financial and social status. To expand medical reach to more needy patients in India, he now has two additional hospitals, and he has a live monthly webcast series, cardiac critical CCC live cases, which started in 2009 and has an audience of more than 25,000 viewers each month in 179 countries. He enjoys teaching other cardiologists and improving patient outcomes with his annual Complex Coronary Cases Symposium and numerous other major scientific meetings, conferences, and live relays. He is also the director of the Top 10 Topics in Clinical Cardiology course every fall and the New York Transcatheter Valve Symposium every December. Thank you, Dr. Sharma, for joining us, and I look forward to hearing from you today.
Beautiful. Thank you, Ivan. And of course, as you said, that exactly at 1 o'clock, we were 9. And he said there will be 40. And within 5 minutes, they became 40. So I'm glad we got the good audience. And with that note, today I'm going to share, update everyone about the structural intervention. I know a lot has been said about the coronary intervention. And today we'll try to show what we are doing. And of course, the CCU, ICU are the very hallmark of their recovery. And all types of patients are coming to you now. Goal today will be update where we are and where actually this field of interventional cardiology is going. So topic will be updates in transcatheter structural heart interventions 2024 plus. And beyond just the TAVI or TAVR, which we have been doing for so many years now, knowing that the first case we did on December 18th, 2010. That was the TAVR.
Dr. Sharma, I think your screen's flipped. You have the presenter mode on if you want to flip it. I'm sorry.
Okay. How do I do now?
And under display settings, up top on the top.
Show display settings, yes.
And then swap presenter, that one, the top one. Yep,
yeah.
That looks perfect. Thank you.
Okay, sorry, good. So this is our topic will be to update everyone. So just to say, the interventional cardiology, lot of therapies besides just the PCI, PTA, of course, the EP and heart failure, quite a bit in heart failure. You probably hear a lot about that. Then obesity, people are putting embolizing the gastric arteries, but that's gone now with the since we got this new agents of Ozempic and so So there clearly a lot of fields even used for impotence and the interventional cardiology. What really has grown, I would say, in last 10 years is the structural heart disease. And in the future, this is the area which is going to grow. Now, why it is going to grow? Because remember what happened in the coronary artery disease. We do asymptomatic patient, we do screening, and then we watch them. And then, of course, we can do various things to prevent the progression of the disease, control the risk factor, bring their cholesterol down, and so on and so forth. Similar thing happens in the valvular heart disease. Although the progression sometimes cannot be inhibited. What that means? That once you develop some valve disease, let's say for aortic stenosis, you develop some calcific or aortic sclerosis, some calcium on the aortic valve. No matter what you do, we have done various trials, give statins, ACE inhibitors, it just continue to progress. So basically, just like our other part of in our body system, we have various stages for the valvular heart disease. That is, A means at risk, patient development of the valvular heart disease, most important being the age. Age is the biggest determinant of the valvular heart disease because patients who get older develop aortic stenosis, develop mitral regurgitation, develop tricuspid regurgitation. Second is the progressive. So that means that you found some, and then you follow up every 6 months or 1 year. Now they start developing the valvular heart disease of the mild to moderate severity, but still asymptomatic. And this is just basically numbers wise. That means for aortic, the velocity, which is normal of 1.2, now became 1.8, became 2. So therefore, stenosis is developing, but patients asymptomatic. Then still but moderate, it's still mild to moderate. Then type C, stage C, is the patients are severely symptomatic. Severe, but still remain asymptomatic. The severe basically means that by criteria, let's say for mitral regurgitation, you have 4 plus mitral regurgitation. You have 4 plus tricuspid regurgitation. And same, for the aortic stenosis, your gradient is more than 40. Velocity is more than 4. But patient says, I do hiking, I do exercise, I run bicycle, marathon, nothing happens to me. So that's the asymptomatic group. Now, what has shown within asymptomatic, they are divided in two. Asymptomatic, so C1 and C2. One is that your ventricle is decompensated. So clearly, one, the ventricle is not involved. Second, you're asymptomatic, but ventricle start dilating. The classical example with the patient with mitral regurgitation. So normal ejection fraction, asymptomatic, but now the ventricle start dilating. So that's the time. Same for aortic regurgitation. So those things are asymptomatic, but ventricular compensation or decompensation. And the lastly is patient now has a severe stenosis and now symptomatic. So that is where surgery had been done over the years in class D only. So why? Because surgery itself has some risk. So, and therefore, it was kept basically for symptomatic, severe disease, valvular heart disease patients. Now, what the transcatheter option has brought is one of the important points that let's go from symptomatic to asymptomatic, but patient has a severe disease. So that's the key. So asymptomatic, but severe. Now we say, why you even have to wait to develop the severe? Because it's going to progress. You cannot stop it. So why not, in selected cases, maybe go to the moderate severity and patients are symptomatic. So this is where the transcatheter options, and I'll show you some of the trials addressing that issue, that let's work on the early stages of the disease process so irreversible damage does not occur. So what does that mean? That by the time you have severe AS or severe aortic regurgitation, ventricle is dilated and then hypertrophied, and even if you replace the valve, the ventricle function may or may not improve, may, let's say, become completely normal, but there is always some scarring. There may be some pulmonary hypertension. There's a residual dysfunction remains. So therefore, let's intervene on early part of the disease process of the our valvular heart disease. And I would say the transcatheter option, which we are going to discuss, is going to give that at present. So all 4 valves, aortic, mitral, pulmonary, and tricuspid, all have been investigated. And this is where the surgery used to be the option and over the years. But now the whole journey started with replacing the aortic valve. And by Anderson, who basically in the sheep, he said, let's take the aortic valve, the sheep aortic valve out and create a kind of a stent graft. There you can see the bovine pericardium and on the stainless steel frame. And then, of course, later on, they become the nitinol frame, suture it, and implanted. It took about 13 years of various experiments to make it perfect. So from 1989 to then April 16th, 2002, 13 years later, first transcatheter valve therapy case was done, which is TAVI. And this was done by which I call the father of transcatheter valve therapy, Alan Crebier. Unfortunately, Alan Crebier died this year in January. He was 78-year-old, but he has done a tremendous job bringing this technique that concluded that non-surgical implantation of a prosthetic heart valve can be safely and successfully achieved with immediate results and midterm success. So this is a tremendous growth, the start of the era of the transcatheter valve. So now let's go to individual where we are. The pulmonic valve, which is when you have the patient at a surgery and then has a leaky, then you do Medtronic melody valve. Now you could be even Sapien. Then green basically means that we got a full approval. It's approved, and now we are using clinically. Aortic is the first one for the adults getting approved for the native, and then, of course, with the valve degeneration of the surgical valve, the Medtronic or the Sapien valve in the aortic position. Then, which to our surprise, very rapidly, we got the tricuspid valve approved. And this is tricuspid. Before that, we were using just, regular aortic valve in the tricuspid position if needed. And putting some clips of the mitral side, but now both tricuspid clip and tricuspid valve replacement, TTVR, complete replacement of the tricuspid valve by Evoke, has been approved by FDA, and we actually had done 8 cases successfully in Mount Sinai. Then clip, of course, the tricuspid clip, we continue. We have done this year already like 30 plus cases. Then where I put the red is for the mitral. The mitral, within mitral, we have 2 areas. One is the tear. That here basically means that you're doing clip for the leaky mitral valve. So that has been approved both for the functional as well as high-risk degenerative. And then the Sapien mitral valve, the various, valve and valve, degenerated mitral valve, prior surgical prosthesis, you can put a Sapien that is approved for this purpose. But what is not approved is the true replacement of the mitral valve, which is called TMVR. While we have the TTVR, is approved by FDA, we're still far away, at least 2-3 years before we can have a full replacement of the mitral valve. So that's still in red. To just come back to the aortic stenosis, I think we all are aware of it's an increasing calcification with age. It's a process of age. Older people get, more aortic stenosis they will develop with the calcific variety. And this still remains the true, which we had learned almost a decade ago, that patients remains asymptomatic and all of a sudden develop symptoms and rapidly have downhill course anywhere from 1 to 5 years, of course, based on the heart failure, syncope, and angina. Heart failure basically means your mortality is 50-60%, which is worse than any cancer. So then what our goal now is that don't wait for symptoms. Can you go a little early, 5 or 10 years earlier in this latent period to intervene so that this rapid progression can be avoided? So what has happened is when we do the image, the aortic valve, we need to see whether it's significant or not. So basically, we do an echocardiogram and CT scan. Those are the tower CT and echo by various criteria. We look into it based on where the calcium is, how things are, and showing the severe AS is valve area of less than 1, mean gradient more than 40, and peak velocity more than 4. At rest, or if patient has low ejection fraction, less than 50, then you do dobutamine stress echo. So this is where make a severe aortic stenosis. That patient is suitable for transcatheter intervention. And in the past, of course, we are doing surgery because these are the patients who live longer, feels better, and have a LV function improves. Now, these are the, as I said, this is the surgical approach. This is the transcatheter approach, Sapien valve with the balloon expandable, self-expanding the core valve or evolute, or in some cases, patients are not suitable for either because they're too sick. Patient come from barely can get out of bed, have bad COPD, and the very limited, doing a daily life activities. So maybe we just do the balloon valvuloplasty BAV. But by and large, the TAVI and TAVR is the one which really has replaced the treatment of the aortic valve. And then this basically can be done by the groin. We used to do various other approaches, but only one left is now the groin, or by transcarotid, appropriate cases, about 4 to 5 cases per year, we do from the carotid. Rest done by the groin, either direct percutaneously, or in some cases, doing the cut down. So at Mount Sinai, this is our distribution of the various valves which we use. Aortic 60% Sapien, 30% is Evolute, and 10% is the Navitor. So this is the case. Aortic stenosis, as you see, patient, this is the LV tracing, this is the aortic tracing, there is a gradient. So this is what aortic stenosis is all about. And if you see here, in this particular case, then you put a valve after dilatation. This is the Sapien valve, and you put a pacemaker at 180 so that valve doesn't move, inflate, and once you're inflated, your balloon deflates after 15, 20 seconds, valve is done and implanted and in a very good position. People do ask all the time, what prevents it from embolizing, going somewhere else? Well, once you have implanted with this high pressure, calcium keeps the valve, so it will not embolize. So this is the key. Now, during procedure, valve may go up and down, so that we call embolization. Sometimes we require two valves. About 2 to 3% of cases, we require two valves. So every year, now actually that number is less than 1%, but because the valves are more, can be captured before they are fully deployed. So, but by and large, once it is deployed, it stays there and are very effective. And look at the gradient, it's disappeared. No more gradient left in now. So we'll say, well, we know now surgery is gold standard. So you want to bring the TAVR to the market, we have to prove it. So this is where the whole heart team started discussion in early 2005, 2007, that what will be the appropriate case. So felt that the cases which are tough for surgeons, let's start do the trial from there. So remember, in the field of our medicine, usually we do trial in the low risk patient first, then we go to increasing risk. But for the TAVR, it's the totally opposite. We say, let's go to the highest risk patient, which many of them cannot go for surgery. And those cases will be great if they can get the TAVR. So compared to just the wait and watch policy, then go to a lower risk from there on. So key is we got an extreme risk, then high risk, intermediate and low based on the STS score of 3, 3 to 8, 8 to 15, and more than 15. And of course, some people are very sick, which I said, there you do a balloon aortic valvuloplasty, no TAVR in those cases. So what we did is we trial from right to left. Compared to a normal dictum of the medicine is, we do a trial in the low risk and go further. But here, we wanted to show that in extreme risk patient, high risk patient, that you have a minimalistic approach, and that will do better. And these are the various trials which have been done. Some complications do occur. And the most important, besides losing a patient, but I can tell you that of the 500 plus patients we do per year, maybe one patient will lose on the table. But what is concerning is the stroke, which happens in about 2 to 3% of cases. Rest, pacemaker, vascular complication, coronary obstruction, and rupture are rare but can occur. We call a 5 big complication: stroke, bleeding, heart block, kidney injury, and the paravalvular leak. The biggest concern is the stroke, because it comes from various mechanisms, not only from the valve, by scraping the great vessels, and of course by the catheter itself. So various of these factors, we have seen patients where the patient went for surgery, neurointervention, because there was a block in the anterior cerebral branch, and they retrieved, and turns out to be a chunk of calcium. So calcium actually came out from the valve and went to. So now we actually have the sentinel device, which goes from the innominate and to the left carotid and retrieve all the embolizers. And of course, only the left vertebral is not covered by this. But the key is that using the devices for cerebral protection, which can be used only in 2/3, because the limitation, because of the tortuosity, and not in every case we have the trial ongoing at present, putting a new device called Protembus. And I'm sure many of the ICU team might know that we have done 2 cases now, and that the catheter goes from the left side. The concept is it goes across all the great vessels and it deflects the plaque. It doesn't retrieve it. It doesn't capture it. It just deflects it. And whether it will be successful need to be seen. Data have shown that you develop a stroke or no stroke, there's a big multi-fold 6 to 8 times higher mortality once you develop a stroke. So clearly we had to avoid a stroke. And there was one original trial of the Sentinel, which showed that it was effective. But most important was the randomized trial. There are 2 of them. One is ongoing, one has already been done, which is the protected TAVR. The patients comparing your TAVR only versus TAVR plus sentinel, cerebral embolic protection. And basically what it show that overall event rate decreased from 2.9 to 2.3, but it was not significant. But what was significant is your disabling stroke, which is the yellow. That 20 means basically it decreased by 40%. So what it does, that it does not decrease all the stroke, but bad one, which we call, that is what matters for us, where those patients either die or go to nursing home. But disabling stroke is decreased. These are the individuals showing that disabling versus non-disabling stroke with the device. So that was the major complication which we need to prevent. Now, these are the various publications of all the trials which have been done. Basically, as you see, every group has been studied with the balloon expandable, with the self-expanding, and published in the various STS risk data and published in NEJM with the conclusion that 8 major randomized trials established the efficacy of TAVR being non-inferior to surgery for death and stroke in various STS risk severe AS patients and lower length of stay. Many of them showed superior and safer outcomes versus surgery, SAVR, except partner 1A. One trial, the only one which showed a little higher stroke, but that was very early stage. Big catheter, and now actually, I'll show you some data that now we actually have a lower stroke with the TAVR compared to surgery. So therefore, TAVR has now become the dominant, safe, and preferred default strategy in management of severe AS. The question now comes, which patient should go for surgery? So that's the other way now. Not that which should go for TAVR, who should go for surgery? So basically now, as I said, the risk is high or low. We don't even use the cardiopulmonary bypass and overly fairly simple procedure. So this is the use of the TAVR in the middle. You can see the black graph. But I want to show this, of course, the growth of our TAVR procedure. About 8,000 cases are done in USA per month with the about 70% Sapien and 25% Evolute and 5% other valves. So one of the very important thing I want to emphasize, this is the surgical volume in blue, and this is a black. Look at the till TAVR went up to like 25,000, means almost 3,000 per month. There was no decrease in the surgical volume. Rather, actually, there was a little uptake because more patients came through the system. What happened here, that many of these patients, remember the AS patients, almost half of them will not go for surgery because of risk. That's where the niche of the TAVR in the early part did. After approval, many patients which could not have gone for surgery. So this was an add-on. And of course, really has been a great growth for us. Now, people ask, you do the valve, how long it's going to last? Well, to me, we have enough data now up to 10 years that it lasts as good as your surgical valve, around 10 years. This is the data from one of the trial. And actually, you see the valve deterioration may be slightly lower with the TAVR valve versus the surgical valve as shown here. So therefore, what is surgery better is a lower vascular complication and lower paravalvular regurgitation, but otherwise TAVR is better in lower mortality, strokes, kidney injury, severe bleeding, new onset AFib, quality of life, hospital stay, and so. So clearly that has led to the approval and class indication for TAVR in all the groups now. So therefore, the decision-making does come, particularly patients who are earlier age, 60, 70, 75, that what you do you do a TAVR versus surgery? So overall, we feel that if patient expectancy is more than 20 years, knowing that the valve life, half-life is 10, so multiply by 2. So if patient going to live more than 20, because you are going to need 2 or 3 procedures on that patient. So it's better to go for surgery than go for TAVR and the TAVR and TAVR. But if patient is going to live less than 10 years, TAVR is completely fine. Now, in between, the decision-making, that whether patients are going to live 10 years, 15 years, or 20 years. So then you make a decision. So this actually is a very nice kind of a document to show that which patients favor surgery, which should go for TAVI, with age, lower age, less than 65, low surgical risk, frailty. If you have, those patients go for TAVI. And valve morphology, unfavorable, go for surgery. Femoral access unfavorable, then go for in those cases, surgery, and concomitant valve disease and complex CAD. And of course, if you have more aortic issues or mediastinal issues, those go for TAVR. So this is a paper which we have just completed, that beyond going with a severe aortic stenosis, TAVR in less than 65 years of age, asymptomatic, moderate AS, concomitant disease, valve-in-valve, aortic regurgitation, and bicuspid valve. So more, and aortic regurgitation pure. So this is actually where regular the TAVR valve will not work because there's no calcium. So it will embolize. So GINA valve is a trilogy valve. It's a very interesting. You have a dock first, you inflate, and then it is stabilized. Then you put a valve inside. And this is where done. So now the data have been very promising, and we think that it will be approved by mid next year. Trilogy valve showed very low complication. These are our data of 500 plus procedures and have done over 3,600. Now we go to the second one, that is the mitral valve. So mitral valve basically repair replacement, repair by the emptier, which is the mitral clip, and then we have the also the Pascal, the same concept, but by the Edward. Then a replacement of the valve itself, TMVR, by Sapien Intrepid Tendyne. So key is the same like aortic stenosis. Once you develop mitral regurgitation, it will continue to have mitral regurg because mitral regurgitation begets regurgitation, ventricles start dilating, and you develop more and more regurgitation despite maximum medical therapy. And the same way that many of these patients do not go for surgery, and of course, then we start taking care of them non-surgical way. So now regurgitation is defined, as we all know, two types: primary or degenerative we call, which is the problem with the leaflet. Then secondary or functional, it's the problem of the heart muscle, LV dilatation. And those are the two types. So, and strategies are two different for the primary or degenerative MR versus secondary or functional MR. So management of MR basically require that guidelines point of view that you study them and then appropriately treat, basically with the heart team. And of course, many of these patients will go for surgical valve repair. But if they're high risk, then those patients come for, as you can see here, that those patients, those who will be high risk, will come for the mitral clip. That's what the FDA approved for this purpose. Then for the functional, it's a little simpler. Because functional MR, the cavity dilated, surgeons have no interest. They don't want to do any. So those are the cases after good guideline-directed medical therapy that they go for transcatheter edge-to-edge repair approved by FDA in 2019. And that really has increased the volume of the clip at Sinai. So medical therapy, mitral clip or mitral valve surgery. So this is the case where severe mitral regurgitation. And then what we do is the transseptal puncture, septal crossing. The patient has this is a TE echo, has a pacemaker already. And then you puncturing the septum, and then you advance the, as you'll see, the device which is loaded on this clip. So this is basically you make multiple handles outside. You navigate, try to go in the right trajectory, right direction from the aortic, from the mitral valve, and then you advance. You open the leaflet, and then you advance across the mitral valve. Once it goes across, then you need to see that it's a good position. Then you start closing the clip, and then that what it does, it teasers, it takes those the leaflets into its grasp, and then you close the clip. So what you do is once you close the clip, you check with the echo that there is regurgitation or not. If you still have regurgitation, means that you're not in the right position, you change the position. You want to have a big grip. About 60% time, we use only one clip, and about 38% time use two clips, and about 2% time use three clips. So basically, once you grasp the leaflet, you've seen less regurgitation, and then identified that, yes, this patient has not developed stenosis. We want to check that gradient also, and then you release the clip. And once clip released, it stays there, and you can see it right there. It stays, sometimes it gets detached, embolized. We have seen all, not here, but many other places. And one case, we actually had the embolized clip into the aortic bifurcation. And patient sent to us, and we took that out. So this basically is the transseptal, and then start putting the clip. Sometime, as I said, rare cases, you do a 3 clips, and the final, this patient with the hemodynamics and the valve doing extremely, extremely well. Mitral clip is a simpler procedure, and it can be done. This is the handle we said. Original data was Everest trial. At that time, about 18-20% of cases where continuous severe regurgitation, those patients require mitral valve surgery. But once you take care of them, the outcome is as good as surgery. So overall, it is reserved for patients with high risk surgery in the degenerative MR and functional MR after guideline directed medical therapy. So there have been two trials to answer that question. One is the co-op trial, and second one is the Mitral FR trial. Two have both disparate results. The overall Mitral FR trial showed no benefit of the clip compared to medical therapy, but co-op trial done very carefully and very diligently by Greg Stone, who was the PI, and of course follow those patients very closely and do a good clip at time zero, resulted in lower mortality and recurrent hospitalization and so. So this basically, and now we actually have the 5-year data that the benefit persists of the clip and so. So also showed that if in the trial, those who were in the control group, once they got the clip, their outcome is as good as somebody who got the clip from the beginning. So clearly that we know the clip, there's no reason at present, patients with appropriate cases with mitral regurgitation should not get the clip. Very benign procedure, complications are less than 0.2%. Sometimes little vascular, no CVA, and patient do very well. We did last year 113 mitral clip. This year we probably do about 125 and so. Overall, as I said, on the top, very low complications and death rate. They will say, well, okay, now we are good with the mitral clip. Why can't we replace all the mitral valve repair of Dr. Adams? No, we have to hold on because we need to do the trials in appropriate patient with percutaneous, which is TAVR versus surgical mitral valve repair. Which one will be better? And that is a part of the primary trial. And this is the all-cause mortality. The patients who have STS of 3 and they are being randomized to surgery, surgical valve repair versus TAVR. Of course, it will take a couple of years to get the results. Now, what are our data? Which I showed that 100 plus the mitral clips we do compared to national. We see it, excellent job being done by our team with the 25 minutes, the device time compared to 55, and of course, lower 30-day and 1-year mortality. Now, the second device, little different, but the concept the same from the clip. It usually works for the shorter clips, shorter, I would say the leaflet length, called Pascal. Their studies have shown it's also very effective. And you can see here that after Pascal implantation, your MR reduction is significant as well as heart failure class becomes less. So there is a trial which compare mitral clip with Pascal, and you see here overall no much difference on the top, but clearly the device time with the Pascal, because it's more newer device, a little more. But more important is that safety point of view, both are very good, but the effectiveness, decreasing to less than 2 plus MR, actually the Pascal did slightly better than the mitral clip. So we using it about 1 to 1.5 per month. We have done total 8 Pascal compared to mitral clip, which I mentioned, we do 8 to 10 per month. But fairly simple device and very low complication. So one is the clip. What happens with the clip, you still have always little residual regurgitation. So then what about changing the valve completely, which is the TMVR? So we know that in the mitral position, if you have a restenosis or degeneration of the prior mitral surgical prosthesis, you can do the Sapien valve, and it's approved for this purpose. So, but that's a kind of valve in valve. But more important is that can we replace the valve by completely, just like the TAVR valve, by using the mitral valve procedures. And these are a few of them. And this is the case. This was the case that who have a prior mitral prosthesis, degeneration, then you put you see the Sapien loaded up on, and then it's done. Regurgitation is gone. So clearly the very good and effective procedure, but right now only for the valve degeneration of the mitral valve, surgical valve degeneration. Now, the native, we're still ongoing the trial called Apollo, which we have been involved, and this is where we have the 1 year the data of the evolute transeptal, no longer surgical cut down, no longer apical, the transeptal, and it works quite well, obliterate the mitral regurgitation, and of course, NYHA classification is much better if patients are in class 1 or class 0. So therefore, the mitral clip is very good. It's good for prohibiting surgical risk, approved for moderate to severe functional mitral regurg after directed medical therapy. And then the TMV are utilizing complete replacement of native mitral valve. So far have shown mixed results because of complex and mitral valve anatomy. So key is that if, let's say, your ideal case, you can do a TEER or you should do a TMVR once it gets approved. Very simple. The TEER is very low risk, but it will not eliminate the MR completely. Always will be 1 plus, maybe even 2 plus. While compared to if you do a TMVR, MR becomes 0. So this all will remain that what is the best approach once we will start having the replacement of the mitral valve by our transcatheter option. Then now comes the forgotten valve we call tricuspid valve. The repair or replacement, there are same way like mitral is called tricuspid TEER, S2 as repair, and then Pascal. The same way we do mitral, the mitral clip, same way the tricuspid clip and Pascal, and then replacing the valve, one by Sapien or by Evoke. Evoke basically is patient has a native the valve disease, and then you can use this full valve assembly, and I'm going to show that. Now, tricuspid regurgitation also is very common actually. It is more prevalent even than mitral regurgitation. And then any degree of tricuspid regurgitation, you can see here, is associated with the increasing mortality, mild, moderate, severe. So key remains that we know it's a bad disease. Until now, it was a forgotten valve. People did not used to think about the tricuspid, but now since we have patients living longer and the mitral clip has been done, patients the aortic valve replacement, we actually have patients who, few of them who had 3. First, the aortic valve replacement, then that time they had MR also and TR also. Then we do about 2 months later the mitral clip. Patient they waited 3 to 6 months. It still continues to be symptomatic because of the TR, and then we did the TR. So one patient we just did a few weeks ago. So key is that many times you do a multiple devices for these patients, but for the individual valve approach. Now, as far as the surgery is concerned, it does not look good in the sense that over the years, isolated TVR mortality of about 12 to 14%. So that's really high. Clearly, and has not changed. So therefore, the surgeons are not excited to work on the tricuspid valve. Contrary, we interventionists are very excited now. Now, as far as the gradings of the tricuspid regurgitation, they call mild, moderate, severe, massive, and torrential, and the majority of them are secondary. That's your dilatation of the cavity. 5% is the intrinsic valve disease, but that's uncommon. Most common is the secondary tricuspid regurgitation. So what you do, basically, if you're the recommendation point of view, that if patient has a severe TR at the time of the left valve surgery, then you do a tricuspid valve repair also. Majority are done as a repair. And then the patients who can see that in the particular cases, that some patients which can be candidate for tricuspid valve replacement or repair, the clip was not part of the recommendation because there was nothing there in 2021. There were some case reports. So until now, if I had to redo this slide, that patients who are planning to do and patients have secondary tricuspid regurgitation and high risk, those will be a very good case at present in terms of the tricuspid valve either clip or the replacement. So clearly there is a field which will be come up that where it should be done. Then of course, if there is a TR as seen on the right side, that annulus is very much dilated and patient already have heart failure, just go for the tricuspid valve surgery. So key is the tricuspid percutaneous intervention has not made to the guidelines, but this will be the group in the center, which I would say will be suitable for tricuspid valve repair replacement. And see there are multiple devices which could work at the one even vena cava, decrease the input from the great vessels. Then cooptation device, which basically is the which we have already. You can see this is being tried at present using the tri-clip. Then suture annuloplasty and replacement of the aortic tricuspid valve particularly the EVOQUE. So complete replacement of the tricuspid valve. So tricuspid is the same way that there's no need for any puncture. The device just had to rotate, go inside the tricuspid valve, and so on. So there is a trial called which was published in NEJM. Dr. Adams is the PI tri-illuminate trial of the tricuspid and showed that there was not much difference actually, except some little satisfactory parameters from the KCCQ. But otherwise, there was no real benefit. But this is the only device which is available, so it got a FDA approval just for that purpose, because there is no competition for this. And Abbott they approved it on April 2nd. TriClip numbers for us is about last year was 12. This year I expect will be about 35. I would say probably maybe 40 actually. Will be 40 the tricuspid clip at present. So this is the case. Patient already have a tricuspid clip. We did a few weeks ago. Had a tricuspid clip about 2-3 years ago. Now you still have a very leaky tricuspid valve. So question what to do? So we said, let's try the replacement of the tricuspid valve, which is the EVOQUE. Now, the same way, you come from the right side and from the valve. Once the position is there, then you gradually advance. You can see here. And then you start unsheathing the valve. So this is the valve, which will have a grasp, tentacles underneath the subvalvular area, and then you replaced it. So now those clips which were there are pushed on one side. There's no longer any benefit, and the tricuspid valve then go right away. What has shown that EVOQUE, the data are very solid, very good, and that led to the approval. And that basically is that the majority of patients in NYHA class 1 or 2, and same case is in terms of tricuspid regurgitation. This is also just like the mitral valve. When we do that, regurgitation completely disappear. Same thing here, that with using EVOQUE tricuspid valve replacement, there's no regurgitation. And mortality 7%, pacemaker rate is 7%, and 4% mortality later. But key is very promising treatment for tricuspid regurgitation. There is an ongoing trial called TRISCEND-2, EVOQUE plus medical therapy and OMT alone. This actually just being planned and will take few years to be completed. The outcome overall we have shown that do quite well, and this also gave it approval of the device by the FDA. So now we have 2 devices approved for tricuspid back to back in February and April. So this is our number. If I take you to my concluding some slides, that of the structural cases we do about 4,000 coronary intervention. We do about 1,100 peripheral intervention, and this is a 785 last year is structural. The 500 is a tower, 101 the clip, then TMVR, replacement of the mitral, those who are surgical prosthesis that you have Sapien done, 8 cases. Then TriClip and the TTVR. TTVR means replacement of the tricuspid valve and the clip, which was 12 clip and 2 replacement. Then some cases you do a BAV and BMV, 107 and the BMV, and then septal ablation, ASD and closure, a small number, and the left atrial appendage closure. So these are all the structural procedures which are done here. So 500 tower, 100 clip, really number 1 center, which does in the New York so far. So if I conclude that the next 5 years will explode with more meaningful changes. Sorry, can you please mute? I'm just concluding my slide now. The next 5 years will explode with more meaningful changes than at any time in the history of interventional cardiology, largely from transcatheter heart interventions and making procedures safer and ambulatory. Ambulatory means there are people are doing it actually as an outpatient, but we don't have the DRG code. So every patient of the structural is admitted overnight. So, but Canada and other people have published that they do the tower in the morning and patient goes home in the evening. But more important, we can say short hospital stay of 1 day. Hence, majority cardiac valve procedures will be done non-surgically by 2030 in patients who are less than 65 years of age. So I would say that for younger patient, I think still there is a room for the surgical. But older patients, 65 and above, you say, well, see, it's 65 old, should be 75. Because Europe, they think it should be 75, but America, maybe 65. So key remains is that with the advancement of the devices, lower complications, and the more people trained, that the more and more these valve interventions will be done non-surgically. So therefore, never been a better time to be an interventional structural cardiologist, which I say. I always say that we try to teach people, besides just ourselves, to show that what are the, we call the tips of the trade, so they can become better operators. We have our CCC Live, which is a coronary. We started in November of 2009. Then we added, in 2012, we added endovascular. And 2014, we added the structural. Structural used to do every other month, but there's a big demand now. As of July, now we are doing every month. So clearly we have 3 weeks, 1 day teaching per month. Wednesday is endovascular. Tuesday, for the third Tuesday is coronary, and first Tuesday is second Tuesday is the structural. So this is the field, as I mentioned, it continues to evolve. We are learning, we are teaching, and of course, all of your experience, particularly in the management of these patients in the ICU, is critical for better outcome and good outcome of these complex patients. And thank you very much. I'll stop here.
Dr. Sharma, thank you so much. That was a really amazing overview and really wonderful about how much these care of these patients and these valves are exploding. I know we work very closely together in the CSDU and in the ICU, and it's great to work with you. I'm going to open up the chat to anyone who has a question. If anyone wants to ask, I'm happy to.
Yeah, it was I call it a roller coaster ride through a wonderful talk on complex things, which in the past were notably hopeless. But I wanted to ask whether arrhythmias have to be controlled before attempts at made at peripheral procedures, and whether they complicate a positioning or maneuvering, etc. That's number one. The other is there a limitation for patients with BMIs over 35?
You mean ejection fraction?
I beg your
No,
pardon?
BMI of 35. No. So let's put this way.
35.
BMI, we actually
35.
did a case. Yeah, we did a case today. BMI was 45. So BMI, I would say BMI, maybe if it is a 60, it will be a trouble. But up to 55 should not be any problem. So that's one. So the BMI, of course, we have to be more careful, more careful with the vascular access, and so on and so forth. So that's basically the issue. So BMI itself is not a issue of the limitation, but sometimes even surgeons will not do those cases.
Yeah.
So that is the biggest thing. Surgeons even will not do those cases. So clearly, the transcatheter option is the better option for those patients just because of their body weight.
Okay. And the arrhythmias.
So then second point was your arrhythmia. So key is the 2 point. One, does the arrhythmia cause any trouble with the procedure? No. But at the same time, the valvular heart disease is very much dependent on heart rate and arrhythmia. So particularly, I give you the example. A patient with atrial fibrillation, the MR becomes 4+. Now you convert back into the sinus rhythm. And about 5 to 10% of cases, that 4+ MR will become mild. Same thing we have seen with the tricuspid. So first treatment when we are dealing with these patients is that can we control the rhythm? Can we normalize them to the normal sinus rhythm by ablation, by shock? So if that's the first treatment for them. Now, if somebody is in the fibrillation for a long time, they probably is less of important. But somebody has in the last 6 months, 1 year, with the corresponding to the valve degeneration with the symptoms, our goal will be take care of the arrhythmia first, because many times arrhythmia is the treatment. And we actually have those who are involved. We had a case on Tuesday. Tuesday was all set to have a tricuspid regurg. Patient was supposed to get at the evoke valve. A patient was in the atrial fibrillation for a few years, kind of. And then, of course, because of the valve replacement, we got an aggressive guideline-directed medical therapy. We have documented 4+ TR on that patient. Everybody was ready. Patient was, we do 2 days a week case patients in the OR. OR 26. They put the patient on the table. So look at this. One month ago, 4 plus TR, patient now goes on the table, and the echocardiographer and anesthesiologist say, guys, what are you doing? There is a mild tricuspid regurg. And sure enough, we look at the rhythm. Now the patient is in sinus rhythm.
Yeah.
That patient has to come out from the OR table. At least the patient was just scrubbed in a little bit on the chest. No puncture was done. But just to say, these things can happen. So idea always is emphasis. Control the rate. And if you can convert the sinus rhythm, see if that makes the improvement. If not, then only you offer this transcatheter procedure. Very important, very valid question.
I find it really interesting. I know Dr. Kier is doing a lot of these where he'll take like the acute mitral regurgs that are too unstable for the OR and doing like a salvage clip as a bridge to getting them to the point where they could do the operations. Where do you see kind of that role going? I find it very fascinating and these really sick patients.
Very important. So question comes in, kind of you say, that what is the role of the tear, mitral tear in cardiogenic shock caused by severe severe mitral regurgitation. We had one case of the tricuspid, which we never did before, but knowing that the clip was only approved in April of this year. So we actually now have 5 cases where patients were in cardiogenic shock and for various reasons, majority of them for the coronary artery disease, actually 3 of them for the STEMI, and then usually, particularly with the circ-MI, they develop the papillary muscle necrosis and severe MR. And now patients require balloon pump on various vasopressor. Surgeons are very reluctant to take those patients. So those 5 patients, I'm sure many others which have been gone for surgery, but I can give you the experience on those 5 patients. So we actually, all 5 of them have been successful. Mitral clip was done. Patient already have a balloon pump, so that's part of the little country, I would say the support for the patient. And these ventricles are not too much dilated, so that's a good thing because acute mitral regurg, but they are in class 4 fulminant pulmonary edema. All did extremely well. Of one patient died about 6 months later. Other 4 have been surviving, and in those 4, 2 of them had a PCI also. We did a PCI, then the clip. And other 3 of them had only the clip. So those patients actually did extremely well. So key is that now we have another device to decrease. And actually data has shown also the centers which have mitral clip, the mortality of the surgical mitral valve repair and the replacement has gone down. You say, how can be relation? Very simple, because complex cases, high risk cases now getting the mitral clip. So presence of mitral clip at an institution has resulted in a decrease of a lowering their mitral surgical mortality because of more complex cases now can be taken care with the mitral clip. Same case like these cardiogenic shock patients, and we are very happy in the sense that the outcomes are very dramatic and all patients are done very well. And that has been published. Actually, there are 2 papers on that, one in JACC and one in JACC intervention, that acute MTR in patient with cardiogenic shock.
Thank you. We have time for one more question if anyone has a question that they would like to ask Dr. Sharma. If not, thank you so much for your time, Dr. Sharma. We really appreciate it, and I hope everyone has a good rest of their day.
Thank you. Thank you. Good day.